Hi, everyone. This is Kristen Whedon. I serve as president of the United Porphyrias Association, and I am joined today by Dr. Bruce Wang, porphyria expert at the University of California, San Francisco. Welcome, Dr. Wang.
Thank you. Good to be here.
We had a live Facebook event on February 24th in the Porphyria Together Facebook group. The recording of that is in our Facebook group right now in Porphyria Together. But we had so many terrific questions from the patient community, and we didn't have time to get to all of them. So, Dr. Wang, you have generously offered to record some of these questions together with me today to share with the broader patient community. So I do want to share, thank you for that. I do want to share that we are going to do additional live streams soon. Our next one will be on May 11th with Dr. Amy Dickey from Massachusetts General Hospital. And you can join Porphyria Together at any time to be able to take part. But thank you, Dr. Wang, again for being here today. We are going to go through questions, and the first questions we're going to ask you are general questions about the porphyrias, and we're going rapid fire. Y'all ready for this? All right.
All right, let's go.
Okay. So, Dr. Wang, the first question is this: are there current treatments for the porphyrias?
So yes, there are, and I'm going to maybe talk about this by the specific type of porphyria. So we may discuss some of these again with later questions. And I'll first start with what are the approved treatments for the porphyrias. So for the acute hepatic porphyrias, primarily affecting those patients with AIP, variegate porphyria, and hereditary coproporphyria, there are two approved treatments for those patients who are experiencing acute attacks. There's panhematin in the United States and heme arginate in Europe and most other places in the world. For those patients who are having frequent recurrent attacks, typically defined by, on average, having 4 or more attacks per year of acute attacks, there's a second medication called, the trade name is Givlaari, that is used for prevention of acute attacks. For EPP patients, there is one approved therapy. The trade name is Scenesse. That's available here in the United States as well as in Europe. It's a subcutaneous injection given typically once every 2 months. There are some additional medications that are currently in therapeutic clinical trials, but for EPP, but not yet approved for treatment. For porphyria cutanea tarda, there are two primary treatment methods for patients. The first is therapeutic phlebotomies to lower total body, but more importantly, liver iron levels. And patients can also get low doses of hydroxychloroquine, which directly lowers and gets rid of porphyrin levels within the liver. For patients with CEP, although there are not necessarily approved therapies for CEP, some of the ones that are fairly widely accepted are for those patients with severe CEP who have hemolytic anemia, transfusions with packed red blood cells. In fact, hypertransfusions to keep the hemoglobin levels high is shown to be effective in suppressing heme production and then accumulation of the porphyrins in CEP patients. And for CEP, also the curative treatment is a bone marrow transplant.
Great. Thank you for discussing current and potential treatments. Now we have the next question is from a patient in the UK who would like to participate in research, and they'd like to know if this is possible.
Yes, there is. And specifically in the UK, I would direct the patient to contact folks. There is a patient organization in the UK, the British Porphyria Association. They work with several porphyria centers. In fact, in the UK, there is a national acute porphyria service, which I believe consists of primarily 4 main academic sites that provide treatment for acute porphyrias. Most of those centers have some experience with the cutaneous porphyrias as well. So that's where I would direct this patient to go for information.
Great. And we can certainly help getting them in contact with the British Porphyria Association. Okay, our next general question, which porphyrias cause anemia, or do they all impact and cause anemia?
Yeah, it's a good question. It turns out that the porphyrias that typically are associated with anemia are the ones that primarily affect the bone marrow, and not the ones that primarily affect the liver. So the two that are oftentimes seen with anemia are first, congenital erythropoietic porphyria, CEP, and in severe cases of CEP, patients have anemia, and a particular type of anemia called hemolytic anemia. And the reason is because of the extremely high accumulation of porphyrins are toxic to red blood cells and causes the red blood cells to lyse. And that's the cause of anemia in CEP. In patients with EPP, this applies to both patients with classical erythropoietic protoporphyria as well as those patients with X-linked protoporphyria. Somewhere between a third of 40% of those patients also have anemia. It tends to be a milder anemia, typically associated with iron deficiency. So those are the two types of anemia where we more commonly see association with anemias.
Great, thank you. And our last general question, for the porphyrias that have photosensitivity or phototoxicity, the question is our sensitivity to sunlight, does it have to do with something about our photoreceptors? That's the...
Yeah, so I'm not familiar with the term photoreceptors. There are photoreceptors in the body. They're present, though, only in cells in the eyes and specifically in the retina. And these are receptors on a couple of cell types within the retina that actually gives us our vision. Other than that, the sunlight sensitivity that we see in the porphyrias are actually primarily due to the chemical properties of the porphyrins themselves and not really to cellular properties of sunlight absorbance. Now, having said that, I should mention that the sensitivity does have something to do with how well the light penetrates our skin. And so, additional barrier protection, basically physical, that's why physical barriers work. That's why we recommend that patients with cutaneous photosensitivity with porphyrias wear long sleeve clothing and wide brim hats. It's that actually provides a physical barrier to block off sunlight. And incidentally, that's also how the mechanism of action of the medication Scenesse, for example, in EPP patients, is that those medications induce our pigment-producing cells in the skin to make more melanin pigment, which essentially just acts as somewhat of an additional physical barrier to sunlight penetrance into the skin.
Okay, great, thank you. Right, this next set of questions is going to be on the erythropoietic protoporphyrias. The first sentence in particular about EPP, or erythropoietic protoporphyria, and XLP, X-linked porphyria. The first question is regarding Scenesse, or afamelanotide. And the question is, how easy should the process be for my primary care doctor to give me Scenesse now? I was told by Clinuvel, the manufacturer of Scenesse, that it can be given from a normal doctor and doesn't have to be a dermatologist.
Yeah, I wish that access to Scenesse is better than it currently is in this country, as well as in Europe, where it is approved. There is limited access to Scenesse, even though it is approved. I unfortunately do not know of a way to improve the access. As an example, my site at UCSF, I will say the largest porphyria center on the west coast of the United States, where I am referred to by other locations, dermatology clinics and other clinics that can give Scenesse. Those patients are referred to me to make the diagnosis. I cannot prescribe and give Scenesse at my clinic, and I cannot give you the reason, and I don't know the reason why. So I think it should be an easy process, but it is not.
Thank you. The next question, should someone with EPP or PCT Porphyria cutanea tarda get periodic phlebotomies for hereditary hemochromatosis?
Yeah, so really good question. Let me answer the PCT aspect of that first, because that's much more straightforward. If you have PCT and you have hereditary hemochromatosis, you should definitely get periodic phlebotomies. Well, if you have hereditary hemochromatosis, you should be getting therapeutic phlebotomies and keep your ferritin at a low normal range to help protect your liver. This is going to be a little bit more complicated issue if you have EPP and hereditary hemochromatosis. And this is in part because we don't fully understand yet what the right relationship, what the right levels are, and really what the relationship is between iron levels and EPP. Partly because patients with EPP respond a little bit differently to iron than those patients who have X-linked protoporphyria. So, and there's some conflicting data about that. I think my general recommendation would be that if you have hereditary hemochromatosis and you have high levels of ferritin, you need to get phlebotomies, because otherwise you are at risk of developing liver problems, chronic liver inflammation, cirrhosis, and a whole host of other end organ damage. So you need to have therapeutic phlebotomies. The question is going to be what should be the right target ferritin level for you if you also have EPP. If you didn't have EPP, generally we keep patients with hereditary hemochromatosis to have ferritin levels certainly below 100 and oftentimes right around the level of 50. The problem is that at that level, some of our EPP patients may develop some worsening of their symptoms. And so this is going to be, again, it'll depend if you have EPP and XLP, and probably also depends on what your protoporphyrin levels are, and would need to monitor that and compare changes in your protoporphyrin levels with change as your ferritin levels change to settle on a target goal for ferritin. So for EPP patients with hereditary hemochromatosis, it's a little more complicated, not quite as straightforward.
Okay, great. Okay, the next question is from someone that states that they have EPP. And the question is, do other EPP patients complain about itchy, burning feet without sun exposure? It is primarily the bottom of their feet at night when they are under the covers.
So in my experience, that's been pretty unusual, that we typically, patients typically complain of burning symptoms, including itchiness, only on the sun-exposed areas. So to have this, especially at the soles of the feet, which have actually somewhat different kinds of nerve endings than, let's say, the back of the hands, the back of the feet. That's a little bit unusual, and I don't usually see that. So I'm not quite sure what to make of these particular set of symptoms, but I don't see it typically with my EPP patients who've had sunlight-induced pain, which again only tends to present in the sunlight-exposed areas.
Thank you. Next question. My 6-year-old son has undergone a bone marrow transplant for severe EPP. Is it possible for photosensitivity to still remain, or is this usually a full cure or fully curative? We have not tested this part out yet.
Yeah, so this is generally a full cure for EPP, but it depends on the degree of reconstitution of the bone marrow. So patients with EPP, your own red blood cells are producing and really high levels of protoporphyrins. When you do a bone marrow transplant, it takes, number one, it takes some time for the transplanted stem cells in the bone marrow to take over and to replace your own red blood cells. Okay, so that's a time that will typically take several weeks into a couple of months. Mm-hmm. And so during that period, you may very well still be photosensitive. And then even after that, bone marrow transplants, the stem cells, sometimes patients still have a small percentage of their own native stem cells remain, even after the initial preconditioning treatment that is meant to ablate or kill off the native stem cells so that the transplanted stem cells can completely take over. But that process doesn't always end up being 100% efficient, and some patients may still have some of their own original untransplanted native stem cells, and those cells may continue to produce some red blood cells, and those red blood cells may still have high levels of protoporphyrin. Okay. Generally, so there's a way to measure that, not directly in terms of the percent of red blood cells that are from the new transplanted bone marrow versus the native bone marrow, but you can get an estimate by looking at what are called chimerism percentages of T cells, other kinds of immune cells that are constituted, that to look at what percentage of these other immune cells are made by the transplanted bone marrow stem cells versus your child's original own bone marrow stem cells. And that gives you an idea of what percentage of red blood cells should be the transplanted red blood cell, we should have normal protoporphyrin levels, and what percentage are the native red blood cells, which are likely still to have high levels of protoporphyrin levels. Ultimately, though, the way to do this is to measure protoporphyrin levels in the blood, in the red blood cells, see what that level is. And based on that, you can get an idea of whether or not your child will still be susceptible to sunlight-induced pain. This question also comes up for CEP patients. And in some patients, it takes a while for full reconstitution of red blood cells with the transplanted bone marrow. It could take 6 months, can take up to a year in some patients.
Okay, great, thank you. And our last question under EPP, or for EPP, is there any medication for EPP for a 6-year-old?
So unfortunately, there's no approved medication for EPP. There's only one approved medication in any case for all EPP patients. Again, that's this medication called Scenesse, but it is not approved for 6-year-olds.
Thank you. All right, now we have a couple questions from patients with PCT, or porphyria cutanea tarda. The first question is from someone who says, I just got diagnosed with PCT in December. However, last February, this all started with allergic bronchitis and really bad sinus infection that caused an inflammation response in my body and hit my GI tract so severe I was unable to eat any longer and had to go to the ER 4 times. So my biopsy taken by my dermatologist showed PCT, but I presented in May with, like, I was in an active acute attack that my dermatologist thinks the ER missed for the window of testing and could be an acute porphyria. Is that a possibility? Meanwhile, this person is still recovering and has the GI upset and localized pain.
Yeah, so a couple of possibilities here. Number one, patients with variegate porphyria and hereditary coproporphyria, the blistering skin lesions look very much identical to that seen in PCT, and it would be very difficult to differentiate between them from a biopsy, skin biopsy. And so the better way to do that would be to check urine fractionated porphyrins and look at the pattern of elevation of porphyrins in the urine and use that to help determine, do you have PCT or do you have potentially variegate or hereditary coproporphyria? Now, if you end up having VP or HCP, those patients can develop acute neurologic attacks on top of having skin symptoms. And so that could be one explanation here, that you actually have a different kind of porphyria than you thought. You didn't have PCT, but you in fact actually had either variegate or hereditary coproporphyria. That's one. Number two, this general question is, can you have more than one porphyria? It is theoretically possible, but I think, statistically, the chances of that are quite low. Again, the way to determine that, and in your case, I think the question here is, why am I having these abdominal pain episodes? And the way to answer that question is to check for levels of ALA and PBG in the urine. Now, I want to highlight that these are heme precursors, and they don't belong to the porphyrin family of chemicals. And so if you check for urine porphyrins, which is what I recommended if you have skin symptoms, it will not include checking for ALA and PBG. So you have to separately order and look for ALA and PBG in your urine if you're thinking about acute porphyria attacks and these severe neurologic episodes.
Thank you. And our last question is, this person was diagnosed with hemochromatosis and PCT in the year in 2000. And this person also has drug allergies. Have you seen this before?
So PCT and hemochromatosis are oftentimes seen together. So PCT, unlike the other porphyrias, can be acquired, meaning that you don't have to inherit an underlying genetic mutation to develop PCT. And what causes PCT is high levels of iron, specifically within the liver, which is why we oftentimes see hemochromatosis and PCT go together. Now, drug allergies is a little unclear to me what is meant by drug allergies, but in general, there are certain drugs, we've already talked about some of them, that induce more heme production, specifically in the liver. And so in patients who have PCT, who then take another medication that induces heme production some more, those patients can have an exacerbation or worsening of their PCT symptoms. So that can certainly be seen. But I should say that PCT patients, if it's confirmed to have PCT, those patients do not develop severe neurovisceral episodes of abdominal pain, even when they take a heme-inducing drug.
Thank you, Dr. Wang. And that concludes our questions for today. We so appreciate you and your willingness to have these rapid fire responses to all the questions from the patient community. You are just a superhero in our eyes, and we're so appreciative of your time and expertise. So,
sure, very welcome, Kristen, and happy to answer any questions that patients have.
Thank you. And with that, I want to share with the patient community that there's no need to wait until a Facebook Live session, that if you have questions about your porphyria or potential porphyria, you can reach out to United Porphyrias at any time on our website, through our email, info@porphyria.org, or give us a call. We will be having another Facebook Live session on May 11th, so patients can join the Porphyria Together Facebook group to listen live, but we certainly don't have to wait until that time to get answers. The Dr. Wang and our other porphyria experts are almost all available, always available to us. But especially thank you, Dr. Wang, for this as the follow-on session to our live session back in February. You are beyond appreciated.
Sure. You're very welcome.